Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. So in this session, I will be discussing a very important topic, that is the pulmonary metastasis. So first and foremost, a very important question is, why does the pulmonary metastasis occurs? And where does the pulmonary metastasis occurs from? So pulmonary metastasis, it results from the spread of extrapulmonary malignant tumors. Okay, so the extrapulmonary malignant tumors these are spread to the lung. Now, what is the route of spread? So these tumors, they are spread through vascular or lymphatic channels. Right, they are spread through vascular or lymphatic channels, or occasionally the tumor is being spread by direct extension as well. So these are the various modes of spread of the extrapulmonary malignant tumors to the lung. And this spread, it occurs via the pulmonary artery, right? Metastasis usually occurs via the pulmonary artery. Right, and typically how do these pulmonary metastases present is, in the chest X-ray you will see the presence of multiple nodules or masses. Right, you will have the presence of multiple nodules or the masses. Okay, so that is what you will observe in the chest X-ray. So remember now, pulmonary metastasis results from the spread of extrapulmonary malignant tumors through vascular or lymphatic channels or by direct X-ray. Metastases usually occur via the pulmonary artery and typically present as multiple nodules or masses on the chest radiograph. Now, the question here is, what is the differential diagnosis for this multiple pulmonary nodules? Right, what will be the radiographic differential diagnosis of multiple pulmonary nodules? Number one is your metastasis, pulmonary metastasis, and the other scenarios where you have this multiple pulmonary nodules on the chest X-rays, it includes pulmonary arteriovenous malformations. Right, pulmonary arteriovenous malformation. Then infections, they can also have this multiple pulmonary nodules, and these infections include abscesses, septic emboli and atypical infections. Then followed by that sarcoidosis, then rheumatoid nodules, then followed by that granulomatosis with polyangiitis. So these are the conditions where you will have the presence of multiple pulmonary nodules in the chest X-ray, and these will be the differential diagnosis for your pulmonary metastasis. Then we have another important terminology called as lymphangitic carcinomatosis. Lymphangitic carcinomatosis, it denotes diffuse involvement of the pulmonary lymphatic network. Right, there is diffuse involvement of pulmonary lymphatic network. right? There is diffuse involvement of the pulmonary lymphatic network. And this diffuse involvement of the pulmonary lymphatic network, it is by, right, it is by primary or metastatic lung cancer. Right, it is by primary or metastatic lung cancer. So this is what is your lymphangitic carcinomatosis. So this lymphangitic carcinomatosis, this is probably a result of extension of tumor from the lung capillaries to the lymphatics. Okay, so why is this particular lymphatic system being affected, or where is this lymphatic system being affected from? That is from extension of the tumor from the pulmonary capillaries. So this we use a terminology called as lymphangitic carcinomatosis, and we have another terminology called as malignant pleural effusion. So metastatic cancer may also present as malignant pleural effusion as well. So one form, right, one form of pulmonary metastasis is in the form of multiple pulmonary nodules, and second form of your pulmonary metastasis can be in the form of even malignant pleural effusion as well. Now, if you take the signs and symptoms of the pulmonary metastasis, symptoms are uncommon as such, but some of the important manifestations include the development of cough, hemoptysis, and in advanced cases, there can be development of dyspnea. Right, in advanced cases, there can be development of dyspnea and hypoxemia. Okay, so that these are the signs and symptoms of the pulmonary metastasis. And most of the times the symptoms are often referable to the site of the primary tumor. This will be your clinical finding. Next, laboratory examination or laboratory findings. If you see, the diagnosis of metastatic cancer involving the lungs is usually established by identifying the primary tumor. Okay, so how will you diagnose, or the diagnosis of metastatic cancer involving the lungs? It is usually established by identifying where is the primary tumor. Appropriate studies should be ordered if there is suspicion of any primary cancer. So this primary cancer, it could be a breast carcinoma, right? It could be a thyroid carcinoma, or it could be colorectal carcinoma, or it could be prostatic carcinoma. So these are the sites of the primary tumor, and these primaries can spread the tumor to the lung in the form of what is called as pulmonary metastasis. Now, these adequate studies should be able to establish what is the primary tumor. For suppose, if the initial studies fail to reveal the site of primary tumor, what are those initial studies? Like history, physical examination, and some basic workup. If they fail to reveal the site of primary tumor, then attention is better focused on the lung itself. Right? Attention is focused on the lung. Now, what is that you have to do on the lung? You have to take the tissue samples from the lung by doing bronchoscopy, right? Or you should be able to collect the tissue samples by percutaneous needle biopsy, right? By percutaneous needle biopsy, and third by VATS. And what does this VATS stands for? That is video assisted thoracoscopic surgery. or thoracotomy. So, by doing either bronchoscopy, percutaneous needle biopsy, video-assisted thoracoscopic surgery or thoracotomy, these investigations will establish the histological diagnosis. Right? These investigations will establish the histological diagnosis. And this will suggest the most likely primary tumor. Right? By doing the study on lung biopsy specimen, this will suggest the most likely primary cancer. So that is about like if the initial studies fail to reveal the site of primary tumor. And another important way how to diagnose is by the cytological studies. Occasionally, cytological studies of the pleural fluid or pleural biopsy will also reveal the diagnosis. So cytological studies of the pleural fluid or the pleural biopsy, right? So these, they help in revealing the diagnosis. And then followed by that, immunohistochemical staining. See, to determine a primary diagnosis, a immunohistochemical staining should be done on a biopsy specimen. Right? Immunohistochemical staining should be done on a biopsy specimen. Like for example, you take prostate specific antigen and thyroglobulin staining. Okay, so prostate specific antigen and thyroglobulin staining, these are highly specific for the prostate cancer, right? And it is highly specific for thyroid cancer. So by doing your PSA and as well as thyroglobulin staining on the biopsy specimen, you will be able to make out the primary diagnosis. And the next important is thyroid transcription factor 1 and Napsin A. Thyroid transcription factor 1 and Napsin A are relatively specific for primary lung adenocarcinoma. Right? These are specific for primary lung adenocarcinoma. Adenocarcinoma is a tumor which is seen in case of non-smokers. And the other point you should know is that you take this TTF1, that is thyroid transcription factor 1. This can be positive in cases of even small cell lung carcinoma. Right? Actually, both of them, they are specific for primary lung adenocarcinoma. But your TTF1 may be positive in cases of small cell lung carcinoma and thyroid carcinoma. Right? And thyroid carcinoma. Whereas if you take this Napsin 1, it can be positive in papillary and clear cell renal carcinoma. Right? Papillary and clear cell renal carcinoma. Okay, so this is about your TTF1 and as well as the Napsin A. Now these adenocarcinomas that demonstrate negative TTF1 and Napsin A staining strongly suggest non-pulmonary primary cancer. So adenocarcinoma, it has to show the presence of TTF1 and as well as Napsin 1. But if this adenocarcinoma is negative for TTF1 and Napsin A staining, that strongly suggests a non-pulmonary right? That strongly suggests non-pulmonary primary cancer. So that is about your TTF1 and as well as Napsin A. I'll repeat this again. TTF1, that is thyroid transcription factor 1, and Napsin A are relatively specific for primary lung adenocarcinoma. Apart from that, your TTF1, it can be positive in cases of small cell lung carcinoma and thyroid carcinoma. And you take the other one, that is Napsin A. It can be positive in papillary and clear cell renal carcinoma. And remember, adenocarcinoma that demonstrates negative TTF1 and Napsin A staining strongly suggests a non-pulmonary primary cancer. That is about your TTF1 and Napsin A. Next, there are certain markers that suggest the primary breast cancer. Now, what are those markers that suggest the primary breast cancer? That is positive estrogen receptor and progesterone receptor. So, positive estrogen receptor and progesterone receptor stains, they suggest the primary breast cancer, right? They suggest the primary breast cancer. Then followed by that, the chest X-ray. So if you do imaging in patients with pulmonary metastasis, the chest radiographs usually show multiple spherical densities. Right? It will show you multiple spherical densities. And these multiple spherical densities, they have sharp margins as well. Right? They have sharp margins as well. And the size of the metastatic lesion, it varies from few millimeters to large masses. Okay? The size of this metastatic lesion, it varies from few millimeters to large masses. And these lesions, where exactly they are present? They are present bilaterally and they are pleural or subpleural in location, and they are more common in the lower zones. Right? They are more common in the lower zones. Okay? And apart from this, please remember, lymphangitic spread and solitary pulmonary nodules, they are less common radiographic presentations of pulmonary mets. So what I mean to say is, this multiple spherical densities with sharp margins, whatever you are seeing in the pulmonary metastasis, they are mainly through the spread from the pulmonary artery. Whereas lymphangitic spread, they are less common radiographic presentations of the pulmonary metastasis. Then followed by that, the CT imaging. The CT imaging of chest, abdomen and as well as the pelvis. Okay, so CT imaging of chest, abdomen and pelvis may reveal the site of the primary tumor. Right, may reveal the site of the primary tumor, and this will help determine the feasibility of the surgical resection of metastatic lung tumor. So, whether can you do a surgical resection or not? That can be made out by doing a CT imaging. And next important imaging study is PET-CT FDG scan, that is positron emission CT fluorodeoxyglucose scan. What is the use of this PET-CT FDG? This is helpful in identifying the site of the primary cancer. Right? And identifying other areas of the extrathoracic mets. So basically, where is the primary cancer and what are the other areas where you have the extrathoracic mets? That can be made out by your PET-CT FDG scan. Then, how do you treat this? Treatment, it consists of treatment to your primary neoplasm. Whatever is the primary neoplasm, you have to treat that, and you also have to treat the pulmonary complications. Right? You also have to treat the pulmonary complications. Then, followed by that, in surgical resection. When you can do surgical resection? See, surgical resection of solitary pulmonary nodule is often prudent in the patient with known current or previous extrapulmonary cancer. Okay, let me tell you in which group of individuals you can do the surgical resection. Surgical resection should be considered only if, right, only if the primary tumor is under control. Right? So, if the primary tumor is under control, then surgical resection can be done. And the patient has adequate cardiopulmonary reserve to tolerate the resection. Right? If the patient has adequate cardiopulmonary reserve, then you need to do the surgical. He is a candidate for surgical resection. And remember, all metastatic tumors that can be resected, you can do the surgical resection for them. Right? All metastatic tumors that can be resected. Then followed by that, effective non-surgical approaches are not available. Right? Effective non-surgical approaches are not available. Then also surgical resection you have to do. And if there is no evidence of extrathoracic metastases that are not controlled, then also you have to do surgical resection. So, surgical resection should be considered only if the primary tumor is under control and if the individual has adequate cardiopulmonary reserve and all the metastatic tumors can be resected and effective non-surgical approaches are not available, then you can do the surgical resection. Then, what are the prognostic features? Right? There are certain unfavorable prognostic factors. These unfavorable prognostic factors, they include shorter disease-free interval, right? Shorter disease-free interval from the primary tumor treatment. If there is only very shorter disease-free interval from primary tumor treatment, that is a very unfavorable prognostic sign. Then, what are the indications for stereotactic radiotherapy, radioablation or cryotherapy? So, one modality of the treatment is you treat the primary tumor. Second, surgical resection. And unfavorable prognostic factors are that if you have very short disease-free interval after the treatment of the primary tumor, that will be your unfavorable prognostic sign. Then you should know what are the indications for stereotactic radiotherapy, radioablation or cryotherapy. See, those individuals who are not suitable for surgery. Okay, so patients who are not surgical candidates but they have solitary or limited metastatic disease, right? They have solitary or limited metastatic disease to the lung. They may be the candidates for stereotactic radiotherapy, radioablation or the cryotherapy. And for patients with unresectable progressive disease, chemotherapy which is tailored to the primary tumor can be offered. So that is about the indication for stereotactic radiotherapy, radioablation or cryotherapy. That is mainly who are not surgical candidates. And those individuals who have solitary or limited metastasis, for them you can do the following procedures. So this is about your pulmonary metastasis. So this is a very important topic, and the characteristic finding in the chest X-ray that you have to make out is multiple pulmonary nodules bilaterally, mainly in the lower zone. So with this, I'll wind up this topic of pulmonary metastasis. Thank you very much.